Welcome back to another episode of Be Well with MS, your go-to podcast for all things related to living a healthy and fulfilling life with multiple sclerosis. I'm your host, Dr. Agnes Storkena, and today we are diving into an essential topic, especially in these times. We're talking about vaccinations and how they relate to those living with MS. It is the right season for flu shots, booster shots, and the questions about the COVID-19 vaccine. For many in our community, the decision to get vaccinated can feel like a complex puzzle. So today we are going to break it down for you, discuss the timing, safety, types of vaccines, and how disease-modifying therapy can impact on your vaccination choices. But first, if you haven't already, make sure to subscribe to our podcast on your favorite platform, and please leave us a review. For your feedback, it always helps us to keep the content relevant and informative. So, let's jump into the crucial conversation about vaccination and multiple sclerosis. Talking about the vaccination, we always have to wait whether there is a pros and cons taking the vaccines, and how does that impact on MS outcomes. And as far as we know, vaccines are not linked to causing increased number of relapses in multiple sclerosis. And there are some big studies that confirms this data. And we know this information for a few decades, but quite recently there was a study published by Grimaldi team in 2023 suggests that inactive vaccines commonly used like for influenza, pneumococcal vaccine, there was no association between the vaccination and the risk of hospitalization of MS relapse prior to the 60 days of the vaccination. So that helps to understand that the inactive vaccines are not linked to MS activity. Talking about the COVID vaccination, it does not appear to increase the risk of relapse or serious adverse events in multiple sclerosis. And that was a meta-analysis study recently looked at vaccination for COVID, whether in the form of the RNA or inactive virus or adenovirus. All these vaccines for COVID were not linked to exacerbation of MS or MS relapse. Overall, the European consensus with regards to the vaccination, which has been published in 2023, Neurology MSJ journal, suggests that in MS patients with or without disease-modifying therapy, the benefit of immunization greatly outweighs any potential risks of the vaccination. And inactive vaccines can be safely used in multiple sclerosis patients receiving disease-modifying therapies. And what about the attenuate live vaccines, whether these are increasing more relapses or not? A decade ago, it was thought out of the 7 patients that were recruited to the clinical trial that the yellow fever vaccine, which is usually a live vaccine, can increase the risk of having a relapse. However, in the last 2 years, studies published in 2021 by Papix and in 2020, Hudner, not large amount of patients, only 32 or 23, but there was no significant worsening of the MS or increase the relapse rate for people who had yellow fever vaccination. I think this is a knowledge that is a bit of a game changing, because we quite often up until now recommended for a majority of people not to have live vaccines because of the worsening or induced MS relapse. And when we talk about the live attenuated vaccines such as varicella virus zoster or measles, mumps and rubella vaccine, which usually are live vaccines, one of the studies recently published in a poster session by Carvajal et al. They looked at the data at their center, and inclusion period was from July 2016 versus November 2021. And all these people between this period of time had at least one dose of live attenuated vaccine. And there was a comparison group looking at the similar patients but who haven't been vaccinated, live vaccine, varicella, or mumps, measles, or rubella virus, and there was no significant difference between the patient two groups who were vaccinated and who were not vaccinated in terms of the relapse rate or progression or new lesions on the MRI scan. Again, very fascinating outcome and robust evidence that people would not necessarily experience MS relapse if they receive live vaccines living with multiple sclerosis. So in summary, as you can see, active and inactive vaccines, generally talking, are very safe in multiple sclerosis. Now, let's look from a different angle now, and I would like to introduce you a new term, immunogenicity, which is used to describe how good something is at stimulating the immune system in your body. So think of your immune system as a team of superheroes that protect you from germs and diseases. When something enters your body, like a virus or vaccine, it can either be really good at getting your immune system attention, which would be classed as high immunogenicity, or not so good, so low immunogenicity. High immunogenicity means that the substances like a vaccine is very effective at making your immune system react and build defenses against it. This is what you want in a vaccine because it helps your body learn how to fight off a specific disease, in this particular case, viral disease. Low immunogenicity means that the substance doesn't do a great job of getting your immune system's attention. In some cases, this might not be helpful because your body won't respond well to the threat, making it easier for the disease to spread. So, when we talk about immunogenicity, we are basically talking about how well something can trigger your immune system to protect from the diseases. How high immunogenicity is like a strong signal to your immune superheroes to get ready for a fight. And we're talking about this because we know that disease-modifying therapies are lowering your immunogenicity. And how does that impact on overall outcome living with MS, taking medicine, and how powerful the vaccines are once they are in your body? So now, if we look specifically at individual disease-modifying therapies and what is like whether the medicine has got any effect on immunogenicity. So the immunogenicity, that means that you have high response to the vaccines if you are taking, generally speaking, disease-modifying therapies. Beta interferons, which comes as Rebif, Avonex, many other brands, glatiramer acetate, natalizumab, dimethyl fumarate, and teriflunomide. These are medicine that you could be reassured that when you are vaccinated, your response to vaccines is equivalent to healthy population who are not exposed with any disease-modifying therapy. Now, slightly impaired immune restoration and responses, in other words, immunogenicity, if you are on cladribine and alemtuzumab. So the timing is super important if you are on these two, one or another therapy. And significantly impaired immunogenicity if you are on anti-CD20 therapies such as ocrelizumab, in some other countries rituximab, or ofatumumab, or you're taking fingolimod, or you're taking maybe Ponvari, or maybe siponimod. All these S1P modulators would significantly impair your responses to the vaccine. Now, timing is super important when your disease-modifying therapy listed that may impair the immunogenicity, you have to think about when is the best time to have vaccination that you have the best protection ever from the vaccine that you receive. So timing, guys, is crucial. Vaccination should be performed at the time of the diagnosis, when you are given new diagnosis, or in the early stages of the disease to prevent future delays in the initiation of the therapies. Okay, so as soon as you have the diagnosis of multiple sclerosis, make sure that you have the vaccination status sorted out, that you have all the possible vaccines that you require. Maybe you're planning future traveling and you require some yellow fever vaccination, which is active. Like maybe you have you're at risk of the lung disease, you need a pneumococcal vaccination, or maybe you're due to have your COVID booster or your COVID vaccination or flu jabs. So do it as soon as you know you're being diagnosed, or at the very early stages to prevent from any sort of delays in initiation of the therapies, because timing of the therapies, that when we start therapy, we usually check your vaccination status these days, because we don't want to make it your vaccines lower efficacy in your body. Now, if you're already known to have MS and you're on established treatments for MS, so timing of getting vaccination is important too. So for the inactive vaccines, such as COVID vaccine, flu jabs, etc., the vaccine can be administered ideally at least 2 weeks before the treatment onset to ensure the complete immune response. Now, live attenuated vaccines, such as yellow fever vaccine, measles, mumps, and rubella vaccine should be administered at least 4 weeks before treatment onset. So, and 6 weeks for ocrelizumab or alemtuzumab treatments. So, timing is crucial, as you gather here, to get the best response and to prevent from having any reactivation of infectious process after you were given vaccination. Well, it's easy if the vaccination is being done just once, like COVID, influenza vaccines. It's just being done as once. But there are some protocols for vaccines, such as human papillomavirus, herpes zoster, hepatitis B, that requires a different regime, such as regular vaccines at baseline, 2 months and 6 months later. That's a common, sometimes at the baseline, 1 month, and then 6 months later, that's for hepatitis B. So various different schemes that are being used to vaccinate people, and clinically it becomes really, really challenging. Sometimes people may start with having a hepatitis B vaccine, for example, before starting anti-CD20, and then they go into having follow-up vaccination, but it lowers the efficacy of hepatitis B vaccine after the third dose. The efficacy only is around 40%, and then fourth dose maybe 20% efficacy of the vaccine. So really anti-CD20 therapy lowers the efficacy of the vaccines, and anti-CD20, that class is ocrelizumab, ofatumumab medicine. And it's important to think about whether there are some ways of having a bridging therapy, some medicine that doesn't lower the efficacy of the vaccination, and go through the scheme of the vaccination if it is necessary for papillomavirus or hepatitis B, if that's the situation, and get the whole vaccination program that involves maybe 3 or 4 vaccinations. And in the meantime, people could be on potentially bridging therapy such as natalizumab, which hasn't got an effect on or reduces the vaccination efficacy. That would be some sort of a discussion with your healthcare providers and talking and considering this option whilst you're having this vaccination and completing vaccination, and then going back on your previous maybe anti-CD20, which is ocrelizumab or ofatumumab medicine. Another way to increase the vaccination efficacy is, and if you are on anti-CD20 infusions such as ocrelizumab or injections of ofatumumab, for example, timing of the vaccination to reach the most capacity and effectiveness could be administered vaccines at least 3 months after the last anti-CD20 infusion. So 3 months later after you had, let's say, ocrelizumab or rituximab or ofatumumab is a bit different way of administrating is going to be 2 weeks after you had your in the middle of Kesimpta cycle, because it's a monthly subcutaneous injections, but at least 2 weeks after your Kesimpta injection you would pursue for vaccination to have the best efficacy of the vaccine that you're administrating. So, to summarize what I've just said, inactive vaccines can be safely given to patients with multiple sclerosis, regardless of disease-modifying therapies. However, be mindful that immune responses can be compromised, specifically in patients who are on anti-CD20 therapies or S1P modulators. So you probably are going to Google what are these names, but the commonly used anti-CD20 are medicine classed as rituximab, ocrelizumab, ofatumumab, S1P modulators, fingolimod, Ponvory, siponimod. These are medicine that are classed as S1P modulators. Now, attenuated live vaccines are also safe, as you learned from this episode, but should be administered before immunosuppressive therapies are started. That's the ideal timing. However, things are different in the clinical practice, and sometimes the expectation is higher than the reality suggests. So the timing of vaccination should be adjusted accordingly. And as you learn to optimize the immunization, the good response of the vaccine in your body, individualized, personalized strategies need to be put in place. Always discuss that with your healthcare providers. If you're not on disease-modifying therapy, it's an excellent timing for live vaccines. But if you are on the live vaccine, so allowing time if it is ocrelizumab that you are on, so make sure that maybe you're administrating that after 3 months from your last dose of ocrelizumab, or at least 6 weeks before you're getting alemtuzumab or ocrelizumab if you're just about to start the medicine. And sometimes in rare cases when people have still active disease and there are some vaccination plans that requires 2 to 3, 4 doses, such as for papillomavirus, varicella-zoster virus. So maybe using a bridging therapy such as natalizumab for completion of the vaccine program, or using maybe a single dose strategies for live attenuation vaccine, which might be giving you some protection. I understand that not necessarily you have to complete the live vaccination or scheme that involves 3 maybe vaccines, but at least single dose strategies for live attenuation virus could give you some protection, and according to recent studies, around 60% protection. So I hope it made sense to you all. If you have any further queries, please do discuss that with your MS-NES or your consultant. But these are sort of a generic remarks and final touches from the European consensus that comes from ECTRIMS and ENA advice how best we should advise people to get vaccines and how make the vaccines most effective in our bodies without having a drop of the efficacy whilst patients are on disease-modifying therapies. And that brings us to the end of today's episode. I hope you found this discussion on vaccinations and MS informative and helpful. Remember, the decision to get vaccinated is a personal one, but arming yourself with knowledge is the first step. And if you have any questions or topics you'd like me to cover in future episodes, please reach out on social media or throughout my website. I'm here to support you and your journey to be well with MS. Don't forget to subscribe, Be Well with MS podcast and the newsletter, and leave me a review. Your feedback is incredibly important to me, and until next time, stay informed, stay empowered, and most importantly, stay well. This is Dr. Agne Strokiane signing off. Bye for now.